So people take on a lot of different roles in their life. You might be married, you might be a parent, you might be an employee, and most of those roles that you take on, you have usually some degree of control over. So you choose your partner, you choose your job, and even if it's something kind of unexpected like becoming a parent, you still usually have at least 8 or 9 months to prepare for that role. But caregiving for an older person is one of these roles that is kind of unexpected. Nobody really ever plans on becoming a caregiver, but it's also not a very uncommon role. I'm Beth Fauth. I'm an associate professor of human development and family studies at Utah State University. So my department covers development across the lifespan, so starting with infancy all the way through adulthood. And my area is at the end of life, so late life, older adults. My department also covers family relationships, and the relationship that I focus on is family caregivers of people with dementia. So what I'm trying to do is look for ways to make family caregivers' lives easier and really optimize their role as a family caregiver. And I hope that people that watch this talk will understand that family members that are caring for somebody with dementia are under quite a bit of stress. I hope that they know that there are resources available to them and that it's okay to ask for help and to get a break. And I hope that they understand the science behind it, that we know that these programs really work. People often ask me what the difference is between Alzheimer's and dementia, and it's a very good question. So dementia is considered an umbrella term. Like there's a lot of different kinds of dementia, and Alzheimer's is just the most common type. So 60 to 80% of all dementias are caused by Alzheimer's disease. So a lot of people say that Americans don't take care of their old people. They place their loved ones in nursing homes, and that is absolutely a myth. So at any given time, there's only 5% of people over the age of 65 living in nursing homes or assisted living. And my students usually think it's between 40 to 50%, and really it's only 5%. So what that means is that the majority of older people are living at home, and if they need care, that care is almost always provided by a family member. So the majority of caregivers, actually 70% of caregivers, have no paid help at all. 40% of caregivers are actually doing what we call high intensity caregiving. So they are not just doing these quick visits with mom, to check in, but they're doing things like feeding, bathing, dressing, sometimes even lifting people out of bed. So it's really important for us to recognize both the large numbers of people that are family caregivers and also the really high intensity work that they're doing. Caring for somebody with Alzheimer's is really difficult. So I mentioned some of the daily care that they need, like eating, feeding, dressing. But there's also some behavior symptoms that people with Alzheimer's have that also makes it pretty difficult. So they may be asking the same questions over and over. They may feel agitated. Even in their own home, they're kind of confused. So all these things make it much more difficult. So the way that we collect the data to evaluate programs is that we have caregivers enrolled in programs either online or face-to-face with a counselor. They fill out a survey where they rate their own symptoms, so how much depressive symptoms they've had in a week. They also rate the symptoms of the person that they care for. So are you exposed to these kinds of behaviors, and how stressed are you by these behaviors? And so we have them fill out those surveys at the beginning before they start the intervention, and then maybe midway through and after, and then usually follow up. So we want to see if these things are sustained over time. And then we just do some statistical analysis where we show, what do things look like? Is it flat, meaning nothing changed? They were enrolled in the program, but we didn't see any kind of movement in their symptoms. Or hopefully we show that, they're less stressed by the symptoms that they've been exposed to, or their depressive symptoms have decreased from before they started the program. We did a study in Utah where we were measuring the frequency of the symptoms of dementia, and we also measured the well-being of the caregiver. We were actually pretty surprised to find that we could predict with up to 72% accuracy whether the caregiver had clinically significant depressive symptoms based only on whether these symptoms were present or absent. So the reason why that's surprising is because depressive symptoms can be caused by a lot of things. And so the fact that these behavioral symptoms were contributing so much towards depression was really surprising to us. So most people assume that it's providing the care that is difficult. And yes, it can be. But really, a study that I worked on showed that it was actually resisting that care. That was what was predictive of caregiver stress and depressive symptoms. So caregivers could feed and bathe and dress their loved one, but when the person with dementia showed resistance, like they were agitated with that care, it was that behavior that actually predicted caregivers' stress and depressive symptoms. Caregivers almost always report that they want to do this job. They really enjoy keeping their loved one at home, and they appreciate that they're providing really good quality care. And most caregivers can report at least one positive benefit for their job. So caregiving can be a really difficult role. I mean, you're with somebody with these symptoms 24 hours a day. On top of that, you're losing the relationship with this person that you've known and loved for a really long time, and that absolutely adds to the difficulty of this. One of the interesting things about caregivers is that even if they're providing care for their family member 24 hours a day, 7 days a week, they often don't identify themselves as a caregiver. So they think of themselves as a son that's caring for mom or as a wife that's caring for her husband. It's just something you do for someone that you love. And so because it's something you would naturally do, you generally don't ask for help. So I generally think that's why caregivers don't know that they can or should ask for help. I think about when I became a parent for the first time. I had my daughter. There may be some things that pop up, like she's having a hard time sleeping. And I had no problem at all calling my sisters, asking my friends that had kids, for advice, looking on the internet for resources. It just seemed completely natural to reach out for advice and for information. And for some reason, people who are caring for someone with dementia just don't think of doing that. They don't really reach out to others. They often feel like they are the only people in this role. And they often don't want to burden other family members by suggesting that it's difficult. And so they really just don't reach out and get the resources that they might need. So this is the focus of my research. This is what I love to do. I design programs for caregivers of people with dementia, and then I evaluate them to make sure that they work. So the programs might have things like education about Alzheimer's disease and what to expect. And they almost always have some kind of stress or coping training involved to help caregivers, manage these really difficult conditions. Educating caregivers is really important because once they understand what's going on inside the brain of somebody with dementia, it may make them a little more able to understand the symptoms that they're seeing and a little bit less frustrated when those symptoms come up. So if they see an image of the brain where you can see lots of damage, lots of neurons that are damaged, it can really help them feel like, oh, this is why the person with dementia is behaving the way they are. It's not because they just aren't trying hard enough or they're kind of being difficult on purpose. The behaviors of people with dementia are just a lot less frustrating when you understand what's going on inside the brain. So another really important part of an intervention for caregiver is giving them a break from that role. We call that respite. Caregivers really need to have some kind of regular time away from the person with dementia so they can be themselves and sort of feel like they can recover a bit. And so this is where friends or neighbors could come in and maybe sit with their loved one for a few hours and get a break, or they could enroll in some kind of intervention program that offers respite. Either way, the research has shown that this is a really effective way of reducing stress in caregivers. We need to find ways to take this role off of just one person. So for whatever reason, in dementia care, there's usually one primary caregiver that does the majority of the work. It may be the spouse, or it might be the child that lives the closest. It might be the child that has the most flexible schedule. But either way, it's usually one person doing the vast majority of the work. So I worked on an intervention where we had caregivers meet with their family members with a counselor, and they sat down and they talked about different ways those family members could help the primary caregiver. So they could come, sit with mom for a while, or they could offer to pay for housekeeping services. That might be for somebody that isn't even in the area but still wants to help. But the most important thing is that we try to get caregivers to recognize this is not a job that they can really do alone. One of the most essential things in a caregiver intervention is helping to teach caregivers how to manage their stress. And there's a lot of options. There's a lot of ways to do this. It could be through therapy. It could be through support groups. Could be through calling organizations like the Alzheimer's Association and getting connected with a counselor there. Whatever they decide to do, the stress management piece is really important. One of my most recent projects was a study where we had an online supportive service offered to dementia caregivers where we were teaching them effective coping skills online without a therapist. So they worked through these different training sessions that taught them some skills in acceptance and commitment therapy, which there's a lot of aspects to that intervention, but what we were really trying to do is help caregivers not really avoid the difficult emotions that they're experiencing in this role, but to become comfortable with those and to try to live according to the values that they felt were most important to them despite this really difficult role. The intervention also included some mindfulness, like breathing exercises, and help them focus on the present instead of on the past or on the future. Caregivers might not know, but there's a lot of resources available to them. They could call the Alzheimer's Association or visit their website. It's a very high quality resource. They can call their area agency on aging. So that's an office. Every county has one, and they have information on support groups and other resources. So it's one thing to know that there are resources available, but what I hope caregivers know and what my research can support is that these programs really work. It's exciting to know that they work sort of both over the short term, right after the caregiver works through maybe some of these classes, but also over the long term. So we're able to show sustained benefits over a long time. So my hope is that caregivers will be encouraged by this, that they will go out and seek these resources that are available to them, knowing, with some confidence that these are good programs.